Perfect. Thank you. Okay, guys, so welcome to those that are here and those that might watch this recording at a later date. We're joined today by Dr. Andrew Jones, um, myself, Hannah, and my colleague Georgia from the AKU Society. And with it being Pain Awareness Month, we wanted to invite Dr. Jones to come and speak to us because he supports our patients here in the UK when they come for their annual yearly checkups in Liverpool, and all of our patients have really great things to say about Dr. Jones. So we thought it'd be really useful to have a session today. For those that are joining and that are here, if possible, if you have got any questions, please wait to the end or feel free to pop them in the chat box and I can ask those to Dr. Jones at the end of his session. So don't feel pressured to have to speak because I know sometimes it's not always for everybody to talk, during these sessions. So either way, and if you don't have any questions at the moment, feel free to message us at a later date. I'm sure Dr. Jones wouldn't mind to come back on those when he's got some time, because I think sometimes we've found in these that people have gone away and thought, oh gosh, I wish I'd have asked that. So I'm sure there'll be that opportunity also. Um, are you okay for me to hand over to you now, Dr. Jones?
Yeah, that's fine.
Okay, so I'm hoping, and if people can't see this, do let me know. In fact, I don't know why I pretend I can't see with my glasses on. Let me just have a look. Can everybody that's in the group, if they can't, let me know, see the screen that I'm sharing? I can see it. Can you see it, Georgia and Dr. Jones?
Yeah.
If anybody that's here can't, please do let me know. And I'm going to be Dr. Jones's assistant today, and moving the slides on. So here we go. Over to you, Dr. Jones.
Okay. Hello, everybody. I'm Andrew Jones. I'm a pain doctor. I've been interested in pain since, well, for about 40 odd years, and I've been a consultant in pain medicine for nearly 30 years. 13 of those years, the last 13, I've also been the pain doctor for the alkaptonuria service. And so I was hoping today to go over a few things about pain, to give you some idea of the physiology of it. So just to introduce some ideas about how we can manage it, and then, and most important, but I think at the end, once we've gone through all that, people can we can have a bit of a discussion about it. And I think I'm going to put some ideas in here. I'm not going to pretend I know all the answers, not least because, as everybody who has suffers from pain will know, it's very difficult to treat effectively. Now, the next slide, please. And this used to be the view from my office window. Unfortunately, it's not anymore because someone's built a hospital in the way, and the office was in has been demolished. So this is historical now, but it just shows my two places of work, which is Liverpool. I work in the pain clinic at Broad Green Hospital, and the Wirral, where I work at the Wirral Hospice St John. Next slide. Now this is Archibald Garrod, who first described alkaptonuria. It's one of Garrod's inborn errors of metabolism. I'm being taught about this because he worked at St Bartholomew's Hospital before me. I know I'm old, but it was still before me. But they would still teach about Garrod's inborn errors of metabolism when I was a medical student. And there's still a Garrod ward in Barts. Next slide. That's just a picture of Barts where I did my medical training. Beautiful fountain, trees which blew down in the hurricane but have now grown back again. And in nice sunny days, they tend to wheel people out in their beds so they can take the sunshine there in the square at Barts. Next slide, please. Right. Now, IASP stands for the International Association for the Study of Pain. And they came up with this definition of pain. It was produced in the 70s. And although it's obviously produced by a committee and is quite clunky, it stood the test of time and it's still the definition which we use today. Um, it says it's an unpleasant. Now, that almost goes without saying, you'd think, but you actually have to mention it is unpleasant. Sensory and emotional experience. I think the emotional thing is probably more important than the sensory thing. People who suffer from chronic pain are suffering. They're not, it doesn't just hurt. There's a whole emotional element to it as well. And so it's associated with actual or potential tissue damage. And that's to get the idea that you don't actually have to have damage to have pain. I think the two most important things from this are the emotional experience and that you don't actually have to have damage. You can have pain when everything's healed up. which we'll go on to soon, and described in terms of such damage. Now, the next slide, please, just to demonstrate that. Now, this is a photograph of a boot which was worn by a young man working on a building site. He jumped off a ladder, landed on a piece of wood with a nail sticking through it, and then a nail went straight through his boot, as you can see in the picture there. He was distraught. It's so bad that his workmates called an ambulance and he was taken to the local accident and emergency department. There, he had to be given quite strong sedation before he would even let them take his boot off. When the boot came off, it was apparent the nail had not actually gone through him at all. It had gone between his toes. So no tissue damage whatsoever, but so distraught he needed quite strong sedation to get his shoe off. Now, the question there is, was he suffering from pain? And I would say yes. If your mates call you an ambulance and you have to have sedation, then you are suffering from pain, but no damage at all. The nail hasn't touched his foot. On to the next slide, please. So this bit, we're going to click through it quite quickly, but this is a very simplified version of what happens when you suffer an acute pain. I'm very clumsy. I've hit myself on the finger, and that immediately causes stimulation of nociceptors. That's pain receptors in my finger. And you get a whole load of hormones there as well, which is why it goes red and swollen. Next, click on again. Now, that goes on that nerve up to the spinal cord, where there are more hormones that are involved, particularly their endorphin, you can see, which is the body's morphine, and the NMDA receptor is where ketamine works. Now, once you've got to the spinal cord, for some reason, the next nervous thing goes right across the other side. We've no idea why, it just does. Click on again. And so it goes up in the lateral spinothalamic tract, which is the bit which carries pain from all over the body up to the brain. So click on and click on again. So it comes up the spinothalamic tract and arrives, click, at the periaqueductal grey matter, click again, which sends it up to the thalamus. Now, the thalamus is a kind of marshalling yard for all the things that come up to the brain, and it decides where to send it. One more click. Now it sends it up to the sensory cortex. So that tells me that I'm hitting my finger, stop hitting your finger. That is what pain's supposed to be. It's just a warning that you're damaging yourself. So, and that's all you need. So if that's the case, click again. And again, why do all these things come into play? Click again, and click once more. And once, that's it. So all these other things come into play. And he said that particularly, it's all feeding into the frontal cortex. That's where your personality lives in your brain. That's where your emotions come from. Now, this is where the bit about the brain, that pain being an emotional experience, comes from. And you might think, why is all that stuff there? Well, first of all, we don't know. Secondly, it must have had a purpose sometime during evolution to have happened, and that purpose is no longer needed now. In the same way that one's appendix is very, very small, but it must have been important sometime in the past. So that's what happens with acute pain. That's how it arrives at the brain. Next slide, please. This is why we know that the frontal lobe, what the frontal lobe does. This chap is called Phineas T. Gage, and in the 19th century, he was working on making the railways in the United States of America, and they ran right across the continent. If they came across a hill, they blew it up, and Phineas was engaged in blowing up things. And he would drill a hole in the rock, put a stick of dynamite into it, tamp it down with his crowbar, which he was holding there, and then light the fuse and retire to a safe distance. One day, unfortunately, poor old Phineas was tamping down the dynamite and it went off, and it blew the crowbar straight through his head, as you can see there. And he survived. It actually took out just his frontal lobes. It didn't hit anything vital, which would have killed him. He developed an abscess later on, which a very brave doctor drained for him. And it basically took out his entire frontal lobe, which meant he completely changed his personality. Before this, he'd been a sober, God-fearing man. After this, he used to lurch around the streets, insulting people and trying to pick fights with them. One of his friends said it was no longer Gage. He'd changed so completely. Good news is he recovered. We know he recovered because it's on the record that he emigrated to Peru and became a stagecoach driver. So there are two things you can get from that. First of all, he got really good cognitive function returning because he had to remember the route of his stagecoach. And the other thing is his personality had improved because you don't get very far as a stagecoach driver if you start shouting insults and trying to pick fights with your passengers. So that's how we know what the frontal lobe does. very important in the transmission of pain, as we saw in the previous slide. Next slide, please. Right. Now, we saw the pain going up through the spinal cord into the brain. When it arrives in the brain, it sends stimulation back down the spinal cord to damp down the painful thing. We've all banged our shins. It hurts like mad. Then it sort of dulls down to a dull throbbing. That's the descending pathways working. They've done some research on this and found out that in people with untreated chronic pain, there's virtually zero descending activity. So when they introduced an effective treatment, whether it was medicines, whether it was injections, whether it was even just talking therapy, I say just, even if it was talking therapy, they got about 40 to 50% of their descending pathways activity back. So when you're suffering from chronic pain, you've got pain coming up, that system we saw before, with nothing coming down to damp it down. Next slide. Now, neuroplasticity is a concept which is really important. When I was a medical student, we were taught that the brain could develop for about 6 months after birth, and then it was set in stone. Nothing else could happen with it. This is almost completely untrue. It just goes to show why a lot of doctors of my age are so unsympathetic about pain, because they don't know about this bit. But plasticity means that although you can't grow new nerves, if you break your neck and you're paralyzed, you stay paralyzed. What you can do is grow new synapses or connections between nerves. And what happens in neuronal plasticity is that nerves branch out and make connections to other nerves that they weren't previously connected to. Now, this is important in that ascending pathway that we looked at, because that spinothalamic tract, which is transmitting the pain up, is branching out and then recruiting other nerves. So you get more and more nerves involved in sending the pain up, and it becomes self-perpetuating, and more nerves are involved, the more intense the pain is. Next slide. And phantom pain is a very useful way of thinking about neuronal plasticity. When you have a limb amputated, the brain loses the sensation from that limb and goes out looking for it, basically. It uses neuronal plasticity to try to produce the limb again. And this is what produces the phantom pain. And you get some very strange effects with people with phantom pain. If you've had an arm taken off, for example, you can touch people on the face with a bit of cotton wool, and they say, "Oh, you touched my thumb," but it's on their face, because the bit of the brain that looked after the thumb is now attached up to a bit of the brain that looked after the face. And this is also an interesting idea in terms of how pain becomes self-perpetuating. Next slide, please. So chronic pain is defined as pain that extends beyond the expected period of healing. You can see this particularly with surgical operations. A good proportion of people who have an operation, the wound will heal up completely, but they still have pain even a year later. And this can also be the case when the pain is originally triggered by, say, arthritis, which is common in alkaptonuria, but again becomes perpetuating. 19% of people studied over the age of 18 years had suffered pain for more than 6 months. 100 million Americans suffer from chronic pain. So it's a really common problem. It's not just alkaptonuria. You can get it in all sorts of people, but it is a particular problem in alkaptonuria as well, which we'll come on to later. Next slide. Now, alkaptonuria is a chronic illness. So you have a certain emotional level because you have a chronic illness that you know can't be cured, feeding back to pain being an emotional experience again. Particularly in alkaptonuria, you get joint damage because of the deposits in the joints. So you can get a fair bit of pain from that. And so people with alkaptonuria have lots of good reasons for pain, and they will get chronic pain. They have pain which is there for more than 6 months, often for many years. So moving on to the next slide. What can we do about it? Well, a lot of people think, well, you've got pain, take a painkiller. It's obvious. Now, this is a very interesting paper from the British Medical Journal entitled "Expect Analgesic Failure, Pursue Analgesic Success." And the basic concept in this paper is that painkillers, quite often in a lot of people, aren't very good, which means that you've got to have an expert pain doctor to juggle things around and find out what's best and what suits people. Now, the reason for this is because most analgesic drugs only work well in a small percentage of people. Pain relief is not normally distributed. This doesn't mean normal in the normal sense. It's a statistical term, meaning that there's a bell-shaped curve, a normal distribution. But pain or response to painkillers is actually bimodal. It says here, some people will get a really good response, 50%. If you can improve pain by 50%, most people are very happy with that. So a lot of people will get a 50% improvement in their pain. Some people will get a very poor response, much less than a 15% improvement, which is not good enough. And about 30% of the population are in that group where they only get a very poor response to pain-killing drugs. And this is all pain-killing drugs. And it applies in acute pain as well. A lot of I used to be an anaesthetist as well as a pain doctor, and a lot of my anaesthetic colleagues used to get very frustrated because they fill people up with painkillers while they were asleep during their operation. And then they wake up in recovery and say it really, really hurts. And they couldn't understand why. This is the reason. A good chunk of the population do not get a good response to painkilling drugs. And the issue here is that you can sometimes play around and find a drug which suits people more than anything else. And also, you can do combination therapy. You can give people small doses of several different drugs. And added together, these drugs will produce a reasonable effect. And because it's small doses, you don't get so much of a problem with side effects. Next slide, please. And this is just a little illustration. These are people who've been given a treatment with pregabalin, very commonly used drug in the pain world. And it shows the line shows their pain score over 14 weeks. And looking at the bottom there, that's about what you'd expect. The bottom line there goes from 40% down to about 5%. Marvelous. Unfortunately, if you look at the top of the graph, there's a chap there who's got 100% at the beginning and 100% at the end. 100 being the top pain score, the worst pain you can get. And if you look at all the white noise in the middle of it, some people's pain's getting better, some people's pain's getting worse. It's not as the drug companies would tell you in their adverts. You've got a pain, take some pregabalin, your pain gets better. Quite clearly, for many, many people, it doesn't. So next slide, please. So we've established that pain is very complicated. There's a lot of complicated neurology to it. It's probably different for every single person with pain. It's probably slightly different to every other person with pain. And managing it can be very difficult. There's a lot of really badly managed, untreated pain out there. So how do we approach this? First of all, very important is exercise. And immediately, I know a lot of people are going to say, yeah, when I exercise, it hurts. It makes the pain worse. And this is true. So you have to exercise in a certain way. One of the concepts is pacing. In other words, you're not going to try and run a marathon in 3 months' time and train up to it. You're going to do a very little piece of exercise and you're going to very, very slowly increase it. And if you do it that way, then you reduce the amount of pain you get because of it. And as you start doing more exercise, the amount of pain you get from it lessens. But it's very important to do it very, very slowly. For example, if you decide your exercise is going to be walking, then, and you haven't done much walking recently, maybe just walk to the garden gate or walk to the post box or something like that. Something very, very limited. Now, what sort of exercise should you do? Well, first and foremost, and vitally important, is you do exercise which you enjoy. But if you don't enjoy it, you won't carry on doing it. So if you like going for a little walk, go for a little walk. Gradually go for a bigger walk. If you like cycling, you can get on your bike. If the weather's bad, you can always get a static bicycle. Some people find that quite fun because you can stick a television in front of it and just watch the telly while you're pedaling around. Swimming can be quite useful because the water supports you and it takes the weight off your joints. You don't even have to swim. If you just go to the pool, walk into it until the water's up to about chest level, and then just walk through the water. It's supporting your joints, you haven't got your weight going through them, and walking through the water is actually quite useful exercise. Physiotherapy, again, lots of people have terrible experiences with physiotherapists. They go to the physio, they give them some exercises, and it makes things hurt much worse. I think the key is to find somebody who is used to dealing with people with chronic pain, and they will understand that if they go to it like a bull at a gate, they will make the pain worse. But if they do it in a very controlled, again, paced way, explain to people how they can improve the muscles around the painful joints, explain to people how they can improve deconditioned muscles, which are painful because of trigger points, then people again will gradually improve. Talking is very important. Going and talking to your psychologist may be useful. The concept here is less of improving your pain score, but of giving you a better quality of life in spite of the pain. Mindfulness and CBT is something I'm familiar with. CBT is cognitive behavioral therapy, and it teaches people how pain works in a similar way to how we've done with the previous slides. The behavioral bit means doing things like exercise. Relaxation is important as well. Now, someone like me, relaxation is having a can of beer and sitting in front of the telly. We don't mean that. We mean things like yoga, things like Pilates, things which give you an improved calming of the brain, because pain is dreadfully amplified by adrenaline. So if you get upset, the adrenaline starts flowing, your pain will get worse. If you have a useful relaxation technique, you can use it to damp down the adrenaline and improve the pain again. I put in shared reading here because this is something that we've pioneered in Liverpool. Shared reading is a technique which is promoted by an organisation called The Reader. It's based in Liverpool, but it's a national organisation. And shared reading isn't, people think it's just a book club or something like that, but it's not. It's actually a definite technique. You have leaders of the group who have been trained in how to facilitate shared reading. They take a piece of literature, it might be a poem, it might be a short story, it might be a play, or it might be quite a long novel, and they read it. And the members of the group, typically between 5 or 10 people, well, they may take part in the reading as well, but an important part of it is to pause and discuss how the literature has made you feel. And there's no rules. People can just sit and listen to other people talk, and they can talk as much as they like. And it's been applied to depression, it's been applied to dementia, it's been applied to prisoners in prison, all with benefit. And so we applied it to people with chronic pain. And we demonstrated the benefit was probably equivalent to that of CBT. And in some ways, it's an improvement on CBT because if you're in a shared reading group, you can go on doing that forever, basically. We have some people in our group who've been in it since it started 13 years ago. Whereas once you've had your CBT course, you've just got to go away and apply it. And you don't get that much in the way of top-ups. So I'll leave you with that idea. We only have the shared reading group for people with chronic pain in Liverpool, but there are shared reading groups all over the country. And if people with chronic pain find their local reading group and go along, they will get the same benefits. So these are all non-medical things that you can do to help with pain. Medication is still important. If someone's in so much pain that they really can't face exercising or physiotherapy, they don't really feel like leaving the house to go and see their psychologist or go to their shared reading group, then they need some sort of help to get them into a position where they can. And medication can help a lot of people. As I showed with the previous slides, it may not help everybody, but if you have an expert pain doctor to help you, you can sometimes come up with a combination of treatments which will get your pain to a level where you can start doing your self-help, doing your self-management. And the other thing which can sometimes help people is injections. You sometimes find there's a part of the body which is hurting, like possibly the shoulder, and you can do a nerve block. It's called a suprascapular nerve block, which again, for a lot of people, nothing's 100% in pain medicine, but for a lot of people, it will reduce the pain in the shoulder, at least for a few weeks or a few months. And if the pain comes back, you can repeat the injection as it's required. And you can do things like trigger point injections, other nerve blocks. And again, this is somewhere where an expert pain doctor can be very helpful. And again, you reduce the pain so that people can start increasing activity and again, employing self-management. So we come to the next slide. That's all I've got to say. I hope we can go on to a question and answer thing now. That slide's getting a bit out of date now. Most people can't remember who it is, but I'll fill you in. It's from the 80s. The chap on the left is Mike Gatting, who was the captain of England. The chap on the right is Shaku Rana, who was an umpire during a test series between England and Pakistan. And Shaku Rana at that time in the 80s became a sort of a byword for biased officiating, and everyone thought he was terribly biased against the England team. He himself thought he was fair as anything. He didn't think there was anything wrong, and eventually Mike Gatting got rather upset with him and told him what he thought of him in this picture here. Which I think, hopefully we can have a nicer discussion than that.
Thank you so much, Dr. Jones. That was really, really useful, and I think a nice tour through pain and understanding it a bit more. Um, is there anybody that would like to start off the discussion, or has anybody got any questions for Dr. Jones while we've got him here? I see Brenda taking herself off mute. Lovely to see you, Brenda.
Thank you. Thank you. I went on to the wrong, for the last one, the wrong Zoom. That's why I was a few minutes late. I found it really interesting, actually, and I have had the pain blocker that you've done for me, and it does really work. Well, for me, it really did work, so it's been great. I've since had my elbow replaced, so that's made it even better now. But yes, I actually don't feel I have too much pain compared to some of my friends. I always say, well, I've got a strong pain threshold, but I don't know if I have or not. But I don't suffer the same. I do use CBD paste, and at the moment, that's all I'm using, and that seems to work for me. I only take a little bit at night before I go to sleep, so I do seem to be okay. Stiffness is something I perhaps do suffer with. And once I get up and I start going, that eases. But I can only do a certain amount, and I find that frustrating because then I've got to sit down, and I don't like that. But I have to do, and it's taken me a long time to realise I have to, but I do try to. But the one thing I struggle with is my feet. Not that they're painful, but I don't have a lot of feeling in them.
Yeah.
My feet to me feel cold, but if you actually touch them, they don't feel cold.
Yeah.
And I find that they feel sort of like I've got socks on all the time.
Yeah. Yeah.
And I don't really know how to deal with that. I put up with it, and I try and get comfortable shoes. And I'm aware of my feet not being right. They feel a bit bumpy and lumpy.
Yeah.
But I do walk on them okay. But that's the only thing I struggle with really at the moment. My neck I do as well, but I know that's getting worse. And I can tell when I look up, I can feel a bit dizzy if I'm looking up. So I try not to look up or stand further back. But that's about it with me, really. I think I do quite well compared to, well, one of my friends in particular.
Yes, I think you do well. And I think it's because if you think of the last slide where you have a little bit of medication, a little bit of intervention, and it helps you to then do your daily activities.
Yeah.
That's a good example of it. And yes, I mean, you're wondering whether you should call it pain.
Yeah.
If it's unpleasant, yes. If it's an emotional experience, then yes. And I think what you're describing with your feet is something you're finding frustrating, so therefore it is an emotional response. And I think it's legitimate to say that that is a problem. What you're describing is called a peripheral neuropathy, and it can have a variety of causes, very difficult to treat. And to some extent, it's a question of building your life around it. So as you say, getting you comfortable shoes and that sort of thing. And this is something I didn't really touch on in the talk, but you've reminded me is very important. Part of suffering with pain is accepting that this is how it is, because that's the first step on starting to do things about it. And it's very difficult because you're accepting that you're not now how you were when you were younger. It's difficult, but unfortunately, you can't start taking steps to improve your quality of life until you've accepted this is how it is. This is where I'm starting from.
Yeah.
I think you've done that as well, very well.
Oh, thank you. I'll keep trying.
Well, that's important as well. Yeah.
Oh, thank you. I did find I went to my friend took me off to her caravan for a weekend, so it was lovely in the lakes. And walking absolutely killed me.
Yes.
I had my walker.
Yeah.
And I was determined. She kept saying, "I'm really sorry." I said, "No." I said, "If I can't do it, I'll tell you." But I was exhausted at the end of each day. But when I came home, I walked down my garden path, and I thought, "Oh, I'm walking better."
Yes.
And that really shocked me.
Yes.
I thought, well, pain and gain, I sort of got some there. But I said to myself, I'll go for a walk each day. And of course, I haven't done.
Yes.
So that's something
I think the other important thing there is not to say, oh, well, gosh, oh, well, that's it. I've had it now. No point trying again. Just go back and do it again the next time. But again, you've illustrated very well there that if you do start exercising, you will improve. And even if you get pain,
Yeah.
be able to do more for the same level of pain. That's quite important.
Ah,
I think the other thing is you can sometimes do deals with yourself. Something
right.
you really want to do, you know it's going to give you terrible pain, you know it's going to exhaust you, and you think, okay, well, I'll accept that because I'm going to be doing what I want to do. I had a patient years ago who loved dancing, and
Oh,
she got put off dancing because she'd be in bed the next day, she could hardly move.
oh,
And then one day she said to herself, right, okay, I'll accept that. I'm going to be in bed for a day, but I'm going to go and have a dance. And she went off and did it, lay in bed for the next day, but felt better because she'd had a dance.
yeah. I can
Mm.
understand that. Yeah. Oh, right. So I will give in and have a rest.
Yeah, yeah, I think that's right. I think it's you don't want to be too tough on yourself.
No.
You can give yourself a day off. People have good days and bad days, and
Yeah.
on a bad day, it's fine just to take it easy.
Yeah. Okay. That's great. Thank you.
Thank you for sharing that with us, Brenda. Is there anybody else that would like to share anything or ask any questions at all? Either that be in person or popping it in the chat function. There isn't any pressure at all. I always feel like I'm putting people on the spot when I ask that. Oh, hi there.
Oh, oh, he needs to unmute.
Hi. Hi, I'm Doris. I have
Uh,
to talk with my cell phone because the computer was not working.
Oh,
Therefore, it's a little bit difficult for me, but I have indeed a question because for me, I work in research, of course, in a completely different subject. But for me, I can understand that it's no pattern behind. I cannot say when I have most of the pain and when it's really more relaxed. Yeah. And of course, I really look at my food, I look at all this exercise, what I'm doing, but I can never say when is it really extremely exhausting with all the pain and when is the pain gone. So is there any trick? Because of course I also write down the things and try really to find a pattern that I can say now it's getting better or now it's not getting better, but I cannot find something like that. Yeah.
no, there is no pattern to it in the way that you're suggesting. Pain varies very, very much. It's because it's such a complex process, as we said, all the things that are going into the ascending pathway, all the things in the descending pathway, plus the frontal lobes and the effect of your emotions. And so it is a very frustrating thing with pain that you can wake up in the morning and you will not know till you get up what sort of day you're going to have. And it is difficult. It does make it difficult. It's it's tricky. I mean, there are obvious things which are causing increase in pain, then you can avoid them. But it's very important not to keep picking up on things that you think might be causing the pain and avoiding doing them because eventually you'll end up doing nothing at all. You'll be sitting in a chair scared to do anything. So if there's a completely obvious thing, then avoid that. But otherwise, I think it comes back to the acceptance again that people with chronic pain will have good days and they'll have bad days. They'll have good weeks and bad weeks. They might even have good months and bad months. And it's not anything you're doing. You're not doing anything wrong when you have a bad day. It's just that's how chronic pain is. And as I was saying to Brenda, sometimes you just have to say it's going to be a bad day today. I'm not going to get as much done as I was hoping to, and not beat yourself up too much.
Mhm. So it's the acceptance, more or less, which I have to learn.
Yeah, I'm afraid so.
Mhm.
And it is really difficult,
Mm.
and it's frustrating for sure.
Mm.
Yeah,
which I think was when you highlighted that at the beginning, Dr. Jones, about the emotional
yeah,
aspect that's linked. I
yeah.
think these sorts of things that both ladies have spoken about here really highlights that element of it, doesn't it? That's really perhaps something that you would overlook if you hadn't, if you hadn't listened to this session or listened to what people are sharing, how um the two are linked so much, that the
Very much
emotional
so. Very
part of
so.
it, yeah.
As I said, I'd almost rather we stopped talking about pain and started talking about emotions, suffering, that sort of thing.
Yeah.
Mhm.
Because when people have worked out their emotions, when they have when people can feel like they're proper people, that they're functioning persons in spite of their pain, that can be very important. That's almost more important than getting pain relief. Because
Mhm.
again, with the best will in the world, people like myself, we never ever take people's pain away completely. just try and get it down to a level where people can function on a level where they can feel some contentment, some quality of life.
Mhm.
Yeah, that's true.
Thank you so much. I didn't catch your name there, but thank you so much for coming on and asking your
It's
question.
Doris. Doris, I was also one
Hi,
of them.
Doris. Hi, Doris. Lovely to see you. Did anybody else in the group, or even Brenda, if you got anything else that you wanted to share?
No, I'm just. I think the emotional side is actually very interesting.
Mhm.
It is getting your mind over it, and I'm off to choir tonight, and I know we get asked to stand, and I find that really hard. And he does say you can sit down, but more often than not, I will stand because you do sing better. But I know when I come home, I'll sleep well.
Yeah.
So I get a good night's sleep.
Yeah.
Yeah.
But yeah, I do think it's mind over matter in a way, isn't it?
Yeah.
Yeah. Not easy.
No, very much not easy.
Okay, well, if we haven't got any more sort of thoughts or questions, as I said, for anybody that missed that at the beginning, if we do go away from this session and you think to yourself, I really wish I'd asked that, please do email me and we will endeavour to get that over to you when Dr. Jones has a minute because he's very busy. So we will endeavour to do that. And thank you to those that have come along. Thank you so much to Dr. Andrew Jones for coming along today. It's been really, really useful to have this session. And we will get this recorded. Well, it's been recorded, but we'll get this out onto YouTube and our website, and will be shared in one of our newsletters as well.
Lovely. Thank you so much.
Thank you.
Thank you, guys. Thank you. Thanks so much for coming. It's been brilliant. Thank you.
See you again. Thanks.
Thank you.
Take care. Take care, everybody.
Bye-bye. Thanks.
Bye. Bye-bye.
Bye.
Bye-bye.
Bye.
I don't know how to turn off.
Georgia, do you want to click stop recording and then I can
Yeah.
try and